Quality Improvement National Campaign, we invite you to visit our website at www.homehealthquality.org. To kick off today's event, we're joined by Cynthia Hammond, Government Task Leader for the Centers for Medicare and Medicaid Services. Before Cynthia talks, I'd like to encourage you to begin submitting your questions now at hhqi@wvmi.org. Following Dr. Lander's presentation, we'll get to as many questions as possible if you submit them now to hhqi@wvmi.org. Now, Cynthia Hammond.
Hello, everyone. Welcome to the presentation on hospital readmissions, the role of home care, with our speaker, Dr. Landers. As mentioned, this is one of many programs offered under the Home Health National Campaign. I and the leadership team at the Centers for Medicare and Medicaid Services are truly excited to support this work. We are especially proud of the fact that so many of you are participating in the campaign. It lets us know that we are actually giving you something that is relevant and useful. If you have any questions that come up after the presentation, please get in touch with us after the presentation and at our website and use the contact link. We will get in touch with you as soon as possible, and we are here to help and support you. Now I would turn it over to Dr. David Winter, the Medical Director at West Virginia Medical Institute, to introduce Dr. Landers. Dave?
Thank you, Cynthia. As many of you know, there's a Home Health National Quality Improvement Campaign which is focusing on uniting home health stakeholders and other healthcare settings around the shared vision of reducing avoidable acute care hospitalizations and improving medication management. Given the important role of home care and the need to improve our understanding of how patients with chronic care needs and those patients being transitioned from acute hospital care back to their homes can be better served, we felt a webinar such as the one we are doing today was both relevant and long overdue. We hope it will provide a starting point for showcasing how these two care settings, both acute care and home care, can assist one another through improved communication that ultimately will serve to make a patient's transition safer, more successful, and efficient. We are extremely fortunate to have with us today Dr. Steve Landers, who has agreed to speak to us on the role of home health care in reducing avoidable acute care hospitalizations. Following Dr. Landers' talk, we will have some time for questions, and again, we would ask that you generate your questions and forward them on to hhqi@wvmi.org, and we will utilize this format to handle questions given the large number of participants on our call today. Dr. Landers is a family physician and geriatrician at Cleveland Clinic, where he directs their Center for Home Care and Community Rehabilitation. Dr. Landers' clinical practice emphasizes in-home geriatric assessment and in-home primary care for vulnerable elders. Dr. Landers is a graduate of Case Western Reserve University School of Medicine and the Johns Hopkins University School of Public Health. He completed his residency and fellowship at the University Hospitals of Cleveland and Cleveland Clinic, respectively. Dr. Landers is the author of several articles, and given his numerous national and international presentations on research, policy proposals, and experience as a home care physician, he will give us just a wealth of information on the topic. Dr. Landers serves on the Board of Directors of the American Academy of Home Care Physicians and was honored as the National Association for Home Care and Hospice's Physician of the Year in 2009. Without further ado, I'd like to introduce Dr. Landers.
Thank you so much, and thank you, Dr. Wenner, for including me in this very important and exciting quality improvement campaign. The subject for today's webinar is reducing hospital readmissions and the role of home care. And I think that I'm hoping you'll find after our talk that there's quite a substantial role for home care in addressing this public health issue of hospital readmissions. Very quickly, I'd like to just give you an overview of what I intend to talk about this afternoon. First, and I'll do it right now, just elaborate a bit on my role. I am a family doctor and geriatrician at Cleveland Clinic, And in addition to my own in-home care practice, also I'm responsible for our home health, hospice, home infusion, and respiratory therapy services. Also, I have provided consulting and received consulting fees and honoraria from a variety of other home health and hospice providers, and if full disclosures are needed, I'd be happy to provide that upon request. I want to go over a number of items that I consider home care's secret weapons in addressing the issue of avoidable hospital admissions, go over the public health problem related to hospital readmissions, review some evidence and examples of home care interventions that work, and discuss real-world opportunities for actually taking this information from these examples and from the medical literature and thinking about implementing them in your own communities. So just in some personal background, in-home care, home visits or home health, what have you, is not a big part of my training as a doctor. Actually, it's not a big part of medical training in general, although in-home care is an ancient concept, you know, invoked in the earliest mentions of medicine in the aphorism of Hippocrates even. But again, often questions of the current relevance. And since I became involved in home care, I've had some interesting comments and notations from my physician colleagues. And I think they're interesting to reflect on because it provides some background for the discussion today. One is, you know, people had asked me, Steve, wow, is that safe? You're really going to do that? A couple other folks said you're like Marcus Welby. I didn't think anybody did that anymore. But then, you know, even more interesting, I've had some colleagues say, we're just trying to figure out best practices after the patient is extubated. What happens outside the hospital is really foreign. And other folks have mentioned to me that this in-home and post-hospital care is like Lewis and Clark for us in various places that I've been. These are some of the things. And so I've been, you know, personally on a learning adventure in home care. My personal home visits and working with other folks in the home care world has afforded me the chance to learn about sort of what is it about in-home care that's unique and potentially offers some opportunities that don't come along with care in other venues. Well, the first thing I noticed right away was that you get a better view of people. I mean, you see practical things like how they manage their medicines and disease self-management tasks up close and personal. Also, you see, you know, environmental risks and the role of the caregiver. And certainly it breaks down barriers to care. In-home care is an access intervention that's very relevant for people with mobility problems, also with housing issues and other barriers to getting care in other venues. These may be social, cultural, education issues as well. One of the great examples I remember, I think it was in the first month or two I began doing home visits, and I was asked to go see a patient who had been re-hospitalized a number of times related to heart failure. And this was a patient in her 80s that had some mild dementia, and it was clear that she was tuned up in the hospital, so to speak, but when she'd go home, things would fall apart again, and she'd come back, and the conclusion was, you know, she wasn't following the plan or the program. And she actually had a few outpatient doctor's visits, and those also, you know, she had some medication changes, and for whatever reason, things didn't get implemented, and she kept bouncing back. Well, when I went to see her, it was clear on my evaluation she wasn't going to be able to manage her medicines without some help because of the memory problems. And I met her husband, who was wonderfully caring and organized, and he was a great resource, and it turned out we were able to keep her, you know, out of the hospital for quite some time by managing her care at home. Well, I discussed the issue with the husband, and what he explained to me is it was just so difficult to get her into the car, out at the office, into the doctor's office, park, come back, set it up so that she could be taken out, and the effort was so ridiculous, and also the expense of paying for parking outside of the hospital clinic was so high that he just couldn't pull it off. So he would never go with her to these appointments, and he wasn't getting the picture. So, you know, again, that enhanced view you get of the caregivers and the access afforded by in-home care for people that have difficulty getting out can be very helpful in addressing clinical problems. Certainly, I think there's a change in the relationship when we take care of people in their home, whether this is a physician or nurses or therapists who are often next to our patients on their bed, across from them at their dining room table. This has a lot of implications, particularly for difficult discussions. And the tough discussions we often have to address with our highest risk patients are goals of care, end-of-life care, paying for custodial care, and that enhanced relationship and that humility of seeing people on their own ground can make an impact. And then certainly there's a notion that you can potentially avoid some iatrogenic and nosocomial complications by providing care at home, particularly for frail elders. And often care at home costs less than care in other venues that may aggregate more technologies and services. And in my adventures, if you will, in making home visits, I've met a lot of people that I didn't really know about, particularly home health nurses and therapists and social workers and dietitians and aides and personal caregivers who really are an army of angels, if you will, that are often sort of out there dodging the snowflakes and the stray dogs without robust physician collaboration. And so one of the neat things was to meet these folks and begin working with them in taking care of the patients that I was seeing in the home. And I don't think the bar was set so high. Actually, I can recall a few conversations where they said, Dr. Landers, you're wonderful. Thank you for returning our call. And then when I returned the call the second time, you know, the response was, you're great. Will you be our medical director? And so I got the impression that physician communication back and forth with home health providers is often fragmented and limited. And I found it very rewarding. And we've seen great examples of patient success stories by collaborating with one another. And the other interesting thing is, like I said, when I started off this practice and became involved in home care, you know, the question was, what's the relevance here? This is something of a bygone era of health care. You know, hasn't this gone away with other vestiges of the past? And interestingly, because of the technology involved, you know, I'm charting on a mobile broadband connection in my patient's home, as are the nurses and therapists that work in our system. We are, you know, our pulse oximeters, we pull them out of our pocket. It's like the size of an ice cube. If we were in need of an EKG, that's a USB plug-in to the laptop. The GPS system helps us get around. Really, I begin to think of in-home care as quite futuristic, and the miniaturization and portability of technology, along with other trends, are driving that. And whereas I started off in the practice thinking of home care as this dinosaur practice, if you will, I'm beginning to wonder if that's not the case for facility-based services in some instances. So I've learned a lot about in-home care from these experiences. Also seeing what's going on in the public health realm. I do have a background in public health. I've always been interested in the world in which we practice, and certainly one of the big drivers of our current practice environment is the cost of care, particularly Medicare and Medicaid spending. And from Congressional Budget Office projections, we can see from looking at that light blue line that the anticipated expenses for Medicare and Medicaid alone could reach 10% of our gross domestic product. And that doesn't even include other health expenses like private insurance and out-of-pocket. So that's a concerning health economic trend. And if we start to ask ourselves, where is the spending of the healthcare dollar, particularly of Medicare spending, it seems like it's focused, about 80% of it, on these patients that are really complicated and that they have 5 or more coexisting chronic conditions. These are the folks that have heart failure and diabetes and arthritis and depression and low vision, among other chronic conditions. And Additionally, we see in the trends, the spending trends, that having chronic conditions and activity limitations, like difficulty walking or transferring from bed to chair, is a particularly expensive proposition. And we can see in the figure that I'm presenting that folks with 5 or more chronic conditions that also have activity limitations, that's the light blue bar, those are our most costly group. And if you look at any number of patients with any number of chronic conditions, those with activity limitations have often double the health expenses. And again, this same story holds true for hospitalizations. Hospitalizations are a large driver for healthcare expenses, and we see that those with 10 or more chronic conditions in one person have the highest rates of hospitalizations among Medicare beneficiaries. So I think when we talk about the problem of hospitalizations and rehospitalizations of chronically ill Medicare beneficiaries, it's important to think of this as a problem of a group of higher risk patients with multiple chronic conditions and activity limitations. And this is, although the avoidable readmission certainly happen across the spectrum, this is a group of patients at particular risk. We know from the work of Stephen Jenks that unplanned readmissions cost Medicare approximately $17 billion a year. I think they estimated that using 2004 data, and that about 20% of Medicare beneficiaries are rehospitalized by 30 days after discharge. Interestingly, half of those don't see a doc before being readmitted. One of the, my own interpretation of that is certainly we need to do a better job with discharge planning and organizing follow-up for patients. But I know that many of the patients that are being rehospitalized or discharged, they have serious access barriers to actually getting to an outpatient visit, even if that were available. I think of my typical patient here in Northeast Ohio in a split-level home where you open the door and you've got two choices, go up or down steps. And when you have a person with multiple chronic conditions, mobility limitations, potentially some equipment that needs to be transported like an oxygen tank or a walker, certainly there's a lot of barriers to getting the care, even if that appointment was made appropriately at discharge. Another interesting point I took away from the Jenks analysis was that the readmission is most often due to another condition or complication. That, for example, the patient who had been hospitalized with heart failure, they'll often be rehospitalized with another problem, such as a urinary tract infection, a fall, delirium, or psychoses. And I do think that this points to the need to think about addressing these problems holistically, that yes, we need to provide good condition-specific management for these patients as they transition out of the hospital, but also we have to be good biopsychosocial caregivers, if you will, in that we look at the whole picture, the functional issues, the comorbidities, and address those parts of the care plan as well if we're going to be successful. So I think that, if we look at post-acute care, post-hospital care, and to some extent chronic care, there's much fragmentation. We work in some respects in care silos between various provider types, be that hospitals and skilled nursing facilities and home care providers and long-term care providers and physician ambulatory care providers. And often there's fragmentation, communication barriers, our incentives aren't always in line, and this can lead to problems like avoidable readmissions, also a declining value. And certainly this issue has been recognized in the process of healthcare reform. And one of the elements of healthcare reform has been encouraging new care models. Among these are potential opportunities to change how we deliver care to maybe align those puzzle pieces better potentially. Examples are home-based chronic care management, independence at home models, accountable care, care transition pilot programs, and I think the most relevant issue for our discussion today is the readmission reduction program, where hospital payments will be adjusted based on performance on readmissions, in 30-day readmissions. And certainly the whole concept of value-based purchasing is certainly relevant to today's talk, as readmissions and avoiding readmissions is likely going to be a part of success, a recipe for success in value-based purchasing models. Now, the hospital incentive payments, those are in the process of being developed and rolled out, but skilled nursing facilities and home health agencies will also, at some point, at least have a plan presented for value-based incentive payments, including measures of efficiency, and certainly managing patients effectively as they transition from hospital to the next venue of care will be a factor in the efficiency of care. So I think if we look at this challenge of an aging demographic with complex chronic illness activity limitations, various fragmentation among provider groups, and the challenge of health reform that, by the way, also comes along with some reimbursement changes to various providers that may pose challenges, that we're really, if you will, we're in a fire. This is a trying time. This is a challenging time. And while we know that challenge provides opportunity, it also it's challenging. And one of the best stories related to challenge in healthcare that I've heard is the story of the Man Gulch forest fire as told by Don Berwick, who is a nominee for CMS administrator. And Berwick, in his piece Escape Fire, talks about the story of this forest fire that the smoke jumpers thought was going to be an easy one to fight, but turned out the winds changed and conditions changed, and it was a devastating event. But that in the course of this fire, one of the foremen got the idea to run ahead of the fire and burn a patch of land. And this creative idea where he burnt this patch of land so that they could escape as the fire burned by was known as an escape fire. And Berwick explains in his writings about an escape fire that there's many analogies to healthcare in this story. One was just why folks didn't see it coming as quite a challenging fire as it was, and talks about also about the collapse of sense making in organizations and why many of the firefighters didn't follow this creative foreman's lead into this patch of land, and many that didn't get ahead of that escape fire perished in this fire. But then also Berwick talks about the creativity of the escape fire and how by this intervention came about and really has become a tool of firefighting. And I've thought since I heard the story and began doing home visits, for me, in-home care is an escape fire, a creative escape fire for many of the challenges that we face with this high-risk chronically ill population. Certainly, in-home care, in Berwick's recipe, if you will, for an escape fire for healthcare is based on the principles of accessibility, healing relationships, and science and evidence. And I certainly think when we do a good job of providing in-home care, that care is accessible, fosters healing relationships, and is supported by the best science and evidence. Well, I want to take a few moments to go through some of the evidence that supports in-home care as a means of reducing readmissions. And the first study that I'm sharing is actually a pooled analysis of 18 different randomized controlled trials. That was
go get it and come back. You won't miss anything. I have the authority to tell her that. I think they can.
The piece done by Phillips that has this pooled analysis of 18 trials. Interestingly, 11 of the 18 trials included home visitation, and they followed patients about 8 months out from the hospital on average among these 18 studies. And those in the intervention groups that had these interventions that involved discharge planning with other post-discharge follow-up, in 8 out of the 11 that included home visitation, readmission rates were reduced. And interestingly, the subgroup of trials that had home visits performed better than the other trials. Now, some of these were international studies with variable follow-up, and again, the intervention was variable. One of the more noteworthy studies included in this analysis of 18 trials was the model developed by Mary Naylor at University of Pennsylvania involving advanced practice nursing transitional care models. Now, those studies all involved discharge planning along with a post-hospital care model. But what if we just do good discharge care planning? Is that going to be enough to reduce readmissions? And there have been two recent publications that I think provide some light on that. One is the New England Journal of Medicine article that looked at correlating the public reporting of discharge planning rates, the HCAHPS discharge planning measure, with hospitals' readmission rates. And it turned out that there was only a very modest association between the HCAHPS discharge planning measure and the hospital compare readmission rates. But an interesting program published by Jack at Boston is the re-engineered discharge planning model. And this is actually a very robust from patient admission to discharge planning process that addresses many of the patient's complex needs, from illness self-management to functional issues and housing and other social concerns. And in that re-engineered discharge planning model, there was an associated improvement in readmissions from a discharge planning intervention. And then another interesting reference related to in-home interventions reducing readmissions is the care transitions intervention. This work has been championed and created by Dr. Eric Coleman, and this is a health coaching model that's based on 4 pillars: medication management, follow-up care plan, personal health record, and people knowing the warning signs and what to do if they're in danger. And this model, in-home coaching, is a key element of the model. And in Dr. Coleman's writings about the model has pointed out that existing healthcare practitioners, particularly discharge planners and home health nurses, are positioned to fulfill this transitions coach role. And in their trial, the intervention patients had lower 30-day readmissions than the controls. And if you do a search of the literature of in-home interventions and reducing readmissions, there's a number of other strategies that have been reported to work. These include telehealth monitoring and telephonic monitoring and coaching, especially when the telehealth component and the telephonic component are combined with other multi-focused interventions, along with home visitation, care coordination, and other services. Medication reconciliation, early physician follow-up, home-based primary care teams, as well as front-loading of home health visits for heart failure patients in one publication. Now, from my experience, in addition to the strategies in the interventions discussed, another important aspect of successful readmission reduction interventions, I believe, will be addressing the elephants in the room. And these are the end-of-life care, goals of care, transitions into home palliative care and hospice care models, because a number of those patients that are frequently being readmitted, they have end-stage disease, and they need a focus not just for improving their overall condition, but also to manage them in the community, sometimes a change in the goals of care and care plan if that's appropriate for the patient. And then certainly custodial care issues. People are often re-hospitalized because of unaddressed safety, protection, personal care, and I think one of the components for us successfully addressing readmissions will be also addressing the patient overall safety and self-care. Shifting gears, I want to talk about our Cleveland Clinic Home Health Agency acute care hospitalization rates. As many of you may know, acute care hospitalization rates are one of the publicly reported outcome measures that will likely become a basis for home health value-based purchasing. And this is an important quality measure that home health agencies across the country concern themselves with. And the green bars represent our Cleveland Clinic's publicly reported rate at the reporting time listed on the x-axis. So our rate that was reported in March of '08 was 29%, and now our most recent reporting was 23%. And you can see there really hasn't been much of a change over that time period in the national and state acute care hospitalization rates. Now, these are risk-adjusted, and you may ask, well, what's the actual observed rate? And the change in that has been from about 28% down to 24%. But the actual publicly reported rate change has been from 29 to 23% over this time period. We have taken, I should say, this is a very much an ongoing process, an approach to use different strategies that we thought would address the problem from different angles, and also some of these strategies don't just address readmissions, but also some other quality issues that are important to us. One thing is our administrators and our managers have made this a very high-profile issue within the home health agency. When they have clinical team meetings with the field staff or they meet together with leadership teams, they discuss the issue of acute care hospitalization and how they can reduce readmissions on a daily basis. This is an important aspect. It's important to people. A few years ago, we implemented a point-of-care electronic documentation system. This helps with communication between providers in terms of having comprehensive clinical information available, communication with managers and other people doing oversight. We initiated a telehealth for heart failure pilot, as well as, in some instances, front-loading of home health visits at the beginning of episodes. We have developed a pilot for a model for transitioning appropriate home health patients into a hospice model. This is primarily just focused on staff education, helping our home health staff have the knowledge and skills to counsel patients and help with the coordination involved with these types of transitions. There's been an increasing involvement of physician medical direction and home-based physician care in our center, which is, I think, I hate to toot my own horn, but I think it's important for dealing with some of those most difficult situations, the real frequent flyer, if you will, in terms of readmissions, people that have open adult protective services cases, conflict between physicians and other providers. I think this is an important piece. In medical record integration, we have a system-owned, this is a health system-owned and operated home health agency. We have a staff physician model that use an enterprise integrated electronic medical record, and we have begun to integrate home care field notes into that electronic record so that that black box of what's going on in the home is open for the physicians, and they can see in their care of patients the frequency and content of in-home care, even just something simple like knowing that somebody was seen by, a particular nurse and how to get a hold of that nurse. But again, I want to point out that home health acute care hospitalization is not the same quality measure as 30-day readmissions for hospitals. And as we think about home care hospital partnerships around reducing readmissions, I think it's important to note that hospitals are being measured and will likely be paid based on 30-day rehospitalizations for specific conditions. And right now those are heart failure, myocardial infarction, and pneumonia. And the home health acute care hospitalization rate, that actually includes people with variable time points. It's not just 30 days. And also, that acute care hospitalization rate includes people that may have been admitted to the home care agency from the community. not necessarily directly from a hospital. So it's not a pure readmission rate. So, but because of the success that we've had in making steady progress in the home care agency with reducing hospitalizations, and also because of those fundamental benefits, those secret weapons, if you will, of in-home care, we have started to look as a health system of how can home care be an integral tool to reducing readmissions for the hospital. And a particular program that we are developing and piloting, we are calling locally Heart Care at Home. And this program is a multi-component intervention for people with heart failure transitioning out of the hospital. And the first thing that we did was look at this from the hospital's perspective. Where do the Medicare beneficiaries, and really we just looked at all older adults, where do they go after hospitalization? It turns out in our health system that most go home with no type of formal post-acute care. Many go to skilled nursing facilities and go to home health agencies. In some cases that's our home health agency. In some cases it's community partner agencies. And also, where do they live? Because if our home care operation, particularly our health system home care operation is going to make an impact, it would need to be in our service area. And it does turn out that most of the heart failure and heart attack patients in our health system live nearby in our service area. So our vision was to reduce readmissions and deliver value-oriented care using multi-component home care management. And again, this is not entirely driven out of the home health agency, if you will. Some of these are in-home services as part of our broader home care and post-acute care operation. We've decided to offer telehealth monitoring with nurse call center follow-up to all patients with the diagnoses or whose doctors think monitoring in the post-acute period is important, irregardless of whether or not home health or other types of post-acute care are appropriate. So patients in this model get monitored on a daily basis, whether or not they're receiving home health and whether or not that home health is provided by our agency. For the patients that are appropriate, usually these would be homebound patients that have a skilled need, they would receive home care as well, home visits. For higher risk patients, we have developed an advanced practice nurse model where they can provide some in-home assessment care plan. And they have a collaborative agreement with the cardiology group and our home care medical directors group. And then for the highest risk patients, we're developing in-home geriatric medicine and palliative medicine consults, physician consults. One of the patients in our pilot, now interestingly, he's not somebody who would have been at risk for the CMS Hospital Compare 30-day readmit rate, because he's not a Medicare beneficiary 65 and older, but an interesting story nonetheless was a fellow with non-ischemic cardiomyopathy who lived fairly close to the hospital, who at the end of last year and into this year was having multiple rehospitalizations, sometimes just after a few weeks or a few days. And this was, if you will, a revolving door of readmission. Now, when he was discharged in April, he was discharged into our pilot program. And to my knowledge, I try to check every day, he's not yet returned to the hospital. So he's gone now over 2 months without a rehospitalization in that program. And that's an example of one of our success stories. And in this program, our readmission rate to date, this is at 30 days, is just under 20% for this program. A couple other interesting points about this Heart Care at Home program. We're measuring health status using a quality of life tool called the EuroQual. We measure this at day 1 through the telehealth monitor, and then again at day 28. And the red bar shows the day 1 measures, and the yellow bars show the day 28 measures. And you can see that in general the patient's health status is improving. And I think it's important to track health status measures and other measures when we're looking at reducing readmissions, because we don't want to reduce readmissions at the expense of people's overall health. And so this is reassuring to us that we're not only keeping them out of the hospital, that their health is improving in this pilot. Now, admittedly, one of the challenges has been access. And what you see in this file is that on the red bar, you have this is the number of people discharged that would be eligible for the program in any given week. And we're not capturing, the bottom line is who we're capturing. So we're in the midst of a process of educating the inpatient care teams and the discharge planners, and also helping to understand how to explain this type of model of care to the patients in order to capture more of them, so that we can actually make an impact on the hospital's readmission rates, which is one of the main goals of the program. And I think our experience, one of the things about this experience of having some challenges in the front end here, I think the future is very bright for this model, but one of the challenges in getting people into the program and the access highlighted that discharge planning in many instances is done from a squeaky wheel approach, meaning that care management resources can be focused often on people that hit length of stay thresholds, people who the care team is identifying as seeming to be high risk, or it's obvious they won't be able to succeed out of the hospital without additional resources. Our social workers and nurse care managers are very attentive to those very difficult cases that maybe involve, a family member in Seattle and another one in Boston, and some conflict, and how do we get past that, and that's where the resources go. But there are the people that may have also be at risk for having unmet post-hospital care management needs that are very much sort of quiet and not the squeaky wheel. They smile and say, "Thank you, doctor, everything's great, doctor, my daughter will be here to pick me up at noon." And those folks, I think, can sometimes get missed. And I think that the discharge planning and case management model of the future, particularly given the challenges we face with the health reform initiatives and value-based purchasing, I think we need to change that model. And I think eventually all patients leaving hospitals, particularly older adults with chronic illness, will need a holistic needs assessment in terms of their functional and other care needs. That they'll have to have some type of health status measurement, as well as identification of appropriate post-hospital care models, and additional resources like some of the examples we talked about in the literature, health coaching, telephonic, telehealth, care coordination, care management, patient education, and self-management resources are all going to be important for all patients, not just the squeaky wheels. And to the point, one of the questions that often comes up in reducing admissions is, who are the high-risk patients, right? The interventions that we have are expensive. They require human resources, technical resources, changing processes, and we want to know who's at risk, who is high risk, and there are some examples of risk prediction tools in the marketplace. But my feeling is that by and large, older adults that are in the hospital with a chronic illness that are going home, they're likely high risk, that whole population. An interesting study that recently was published in the Annals of Emergency Medicine showed that even patients, they looked at older patients that were admitted to the hospital from the emergency room and then discharged within the next 24 hours from the hospital. And you would think that, if they only needed to be in the hospital for 24 hours or less, these must have been pretty low risk. But even in that group, at 60 days, 2 out of 100 had died, and 11% were re-hospitalized. And I think it goes to point out that really most older adults that are admitted with particularly those with chronic conditions, are at risk. And we really need to think about things from a global standpoint in terms of a lot of these practices in regards to transitioning patients successfully are likely universal, that will apply to most patients, not just to a subset, although some of the interventions certainly are so resource intensive, we have to find ways to triage. So I think that there is certainly a leadership role for home health agencies in reducing readmissions. Now, we talked generally about home care interventions and about home-based models of care, but not specifically about home health agencies. But I think if we get real and practical about how we would really implement these new strategies on a wide scale, the infrastructure and the expertise in our country rests in home health agencies. We have over 9,000 Medicare certified home health agencies that do over 100 million annual home visits with nearly 900,000 employees and 250,000 FTEs. This workforce has a history of documenting outcomes and quality-based care because of the CMS quality improvement initiatives, that they are often using new technologies and new conceptual care models, and they have often the local expertise that's important to decide what are the best strategies. Certainly the in-home care models that would work in a 100-floor high-rise senior community in Manhattan may be different than in the rural communities, in the southwestern United States. The issues are different, and there are home care agencies in almost all these locations that have local knowledge about delivering these home-based interventions and adapting those wonderful strategies we see in the literature to being truly successful implementations. And then certainly many of the functions that need to happen for patients to successfully transition home without being readmitted are already covered in the Medicare home health benefit: teaching and training activities, observation and assessment, care plan evaluation and management for complex situations. Certainly those covered services are very relevant to what we've discussed today. And additionally, the home health eligibility, while it is restricted to patients that are homebound, this reasonably well approximates patients at risk, given that the folks that are at risk do often have activity limitations, do have difficulties. So it's not a perfect approximation, but it is it's one to make note of. So in summary, home care and home health in particular are especially well positioned to impact hospital readmissions. It appears that multi-component cross-venue models show the best promise. Looking at the landscape of the future, universal and holistic hospital discharge planning process is likely important for most patients with chronic illness, even if they're not the squeaky wheel in terms of difficult to discharge. And then implementation issues are likely important along with the strategy, and taking a local approach in various communities and settings is I think, instructive. One of my colleagues said, "Steve, if you've seen one hospital, you've seen one hospital." And I think that should be in the front of our mind in making recommendations. So thank you so much for your time this afternoon. I hope this was useful, and I'd be happy to try and address any questions.
Okay, thank you, Dr. Landers. Our first question comes from David K. David asks, how can care transitions intervention coaches using Dr. Eric Coleman's model and other patient activation tools work effectively with home health agencies to enhance patient activation and reduce avoidable readmissions?
I'm not an expert in the care transitions intervention. Other than that, I can say that I've impressed with the literature, and I've heard many presentations of the model being successfully implemented. My instinct is that home health agencies offer an incredible resource to actually take this wonderful strategy and implement it on a wide scale. We have not traditionally had somebody called a transitions coach in our health system, and actually creating that person and scaling that up is quite challenging. But certainly many of the skill sets, as noted in one of Dr. Coleman's piece, is one of the skill sets I think that could be adapted to this is our home care coordinators, home care nurses, and therapists and liaisons. I think appear to be well suited to play this role. So I would say that home health offers an infrastructure to actually implement these evidence-based interventions.
Okay, our next question comes from Della Andrews in Oklahoma. Have you had any success in decreasing the end-stage renal disease population readmissions?
I personally don't have experience specifically with efforts for that population. I'm sorry.
Okay, our next question comes from Mary Allo in California. Mary asks, do you do home visits yourself? If so, how does this fit into the current PPS Medicare A model?
Yes, I make home visits, and that's how I got a chance to learn about, patients' needs and also all the different types of clinicians out there. And home visits are covered under Medicare Part B as long as they're medically necessary in terms of physician home visits and nurse practitioner and physician assistant and even podiatry and other types of visits. And these often complement the PPS home care when there's a need for both physician and other services, and in some cases they're entirely separate. A patient may need a physician home visit that does not need PPS home health, and vice versa.
Our next question comes from Misty Kevich in Pennsylvania. Misty asks, who is managing the patients that are receiving telehealth but are not on home care? Is there a charge for patients receiving telehealth without home care?
First, there's no charge. We're offering this as a quality improvement initiative, and even people without insurance whose doctors recommend this are being included in our pilot. In terms of the management, we do require a physician referral at the time of hospital discharge, and we clarify as part of that plan beyond the telehealth nurse who's responding to the alerts and talking with the patient, we clarified who that follow-up will be with. In the case of a patient who's not a home health agency patient, that telehealth nurse might interact directly with the patient's primary care office or cardiology practice to implement their care. In the case of a patient who is receiving home health, it may be a home health clinician that telehealth coordinator is interacting with. And in some cases, it's physicians doing home care, nurse practitioners doing home care. So it's varied.
Our next question comes from Ron Dries. Ron asks, do you have any advice on getting physicians more involved in home care? Our hospital cardiologists do not like home health because they get too many calls.
Well, I think for one, the world is changing, and as they become more concerned about post-hospital outcomes, it may be a great time to readdress these discussions. In terms of the and also, it's just patients are so grateful and appreciative when doctors help them stay at home, and it's just incredibly rewarding, and they should know that. Now, one of the parts of the model that we put in place is that nurse practitioner model, and so for our heart failure cardiology group, who we anticipate having a lot of patients, involved in these programs, they're setting up this home nurse practitioner role, and hopefully that use of a nurse practitioner or physician extender will help mitigate some of those interaction needs. Now, certainly with the conditions of participation for home health agencies, almost everything needs to go through the physician at some point, but we believe that nurse practitioner role will help make that interaction as efficient as possible for those docs.
Our next question comes from Leslie O'Day. Leslie asks, please explain the tool that you use to determine health status outcomes.
The tool that we're using is one called the EuroQual or EQ5D, and it just has 5 dimensions with a few quick questions. It's a publicly available measure that if you look up EQ5D or EuroQual, you can find that, and if you would like some specific information, don't hesitate to email me, and I'd be happy to try and point you in the right direction.
Another question comes from Roz Farber, who asks, on the slide for heart care at home status outcomes, what is the name of the health status measurement tool that is used, and how can I get it?
Again, we were using the EQ5D or EuroQual.
Okay. Our next question comes to us from Gina Glass. Gina asks, what criteria did you use to distinguish between homebound only, high risk, and highest risk patients in your heart care at home project?
We are not right now using any specific score or algorithm to determine these things. I think that those categories can be looked at as continuum. And you know, right now the high risk, we're identifying the high risk people as those people that the people involved with their care are saying, wow, there's something really risky going on, or this patient is really declining rapidly, or their parameters are changing. But those are more generic. Over time, we hope to develop the experience with the population to actually have more quantitative information as to who benefits from exactly which model component. We're not quite there yet.
Okay, our next question comes from Susan Davis, who asks, we see the state departments moving away from traditional home care with actual reportable outcomes to independent individuals who are not required to do this outcome reporting for the state. With this in mind, how do we demonstrate the value of the industry that's been caring for patients in the home since 1965?
Well, certainly I don't disagree that tracking outcomes and reporting them is very important. In regards to the Medicare home care population, I'm not aware of any initiative to decrease the amount of outcomes reporting. I suspect on a state-by-state basis, as you're alluding to, there may be some instances in custodial care programs or non-Medicare, Medicaid-based programs, there are some changes. I'm not familiar enough with those specific state changes to comment at this point.
Our next question comes from Wallace, who asks, it's great to hear about the hospital readmission information for 30 days. From a hospital perspective, we want to start some interventions in collaboration with home care providers about this. Part of the problem is the large number of home care providers in our area. Do all home care providers adopt the interventions for decreasing readmissions among heart failure, pneumonia, myocardial infarction patients? How do we know if home care agencies are following national best practices?
I think it's important for hospitals to actually go out and meet with those providers and find out. There is variation in terms of the technologies being used by home care providers. There's variation in the conceptual models and frameworks of care being provided. There's variation in terms of the training in some instances. And so I would certainly encourage hospitals really look closely. Now, ultimately the decision for provider is based on the patient's determination, but the patients are often really clueless in all this, and it's important that physicians and case managers and nurses and social workers across all venues of care understand the differences between the home care providers in their region. So certainly one thing to look at is their publicly reported outcome measures. It is something that provides some insights as well, although it doesn't tell the whole story.
And we have time for one final question before we wrap up. This comes from Susan White-Knight, who asks, what do you think is the best approach to educate physicians about home care?
I think it's when they get feedback from the patients that it's been successful, it seems to resonate. And so, when we are interacting in home care with a patient of another physician, I think it's, we may want to mention to the patient, make sure you tell Dr. So-and-so about what we've been working on at home, and that could help raise awareness. I certainly think there's a big need for more medical journal articles, more continuing education, more actual requirements for home care related concepts in formal education. It's just, I mean, personally, I've fallen in love with home care, and I would have figured that out probably sooner, but wasn't exposed to it in great depth as part of my training. And actually, I did have some home care experiences, and my training programs took pride in those as being sort of ahead of the game, but they were fairly limited. So I think that we really need to, especially as we look at caring for an aging population, think about how do we integrate in-home care into physician education better. And I think physician house calls are a good opportunity. I sometimes include residents and students in my home care, and they really get a kick out of it and learn a lot. And I think it helps on, you know, when we just have the students or residents go out with non-physicians, certainly I think that that's useful and interesting and they learn a lot, but it does, I think, the students, the smart ones, start to question the relevance. Well, hey, why aren't any of the doctors doing this? It's just, you know, my colleagues in nursing, and I think it's nice if you do have home visiting physicians to include them in medical education, not just because there's a need for physician home visits, but just so that they can understand the importance of in-home care in general.
Okay, thank you so much, Dr. Landers. Now to conclude today's session, Dr. David Winter will deliver the closing remarks. Dr. Winter?
Thanks, Dr. Landers. I know I speak for all of the participants on the call today, and we really would like to thank you for your wonderful presentation and your various thoughts on how home care can improve both care transitions as well as hospital readmissions. We'd like to encourage all of the participants to view our website for the national campaign. That is www.homehealthquality.org. This webinar by Dr. Landers is being taped or has been taped and will be available on our website. We're going to do our next webinar on September 29th, and our guest speaker will be Dr. Jane Brock, who will be sharing many of the findings identified thus far in the 14-state subnational care transition projects that CMS is overseeing. Once again, thank you to Dr. Landers, and thank you to all the participants on the call today. We wish you a good rest of your day. Thanks.
World-class service is central to the mission of Cleveland Clinic. Our commitment to world-class service means that every Cleveland Clinic employee is dedicated to providing the highest quality patient care. Thank you for the confidence you place in us when you choose Cleveland Clinic. Please hold. A member of our staff will be right with you.